Welcome back to the deep dive.
Yeah.
Today we aren't just looking at an incremental step forward in oncology. We are looking at a data set that essentially breaks the scale.
Yeah. Completely shatters it.
Right, we're talking about relapsed or refractory
Mm.
multiple myeloma, which, as you know, is a condition that is historically incredibly difficult to manage once those standard lines of therapy fail.
Absolutely.
And to give you a sense of where we are heading today, I want you to hold two numbers in your head right now. Just keep these in mind. 30% and 83%.
Two very different roads, as it turns out.
Exactly. You have patients on the standard high-quality care path and then patients on this new experimental path. And you fast forward 3 years. On the standard path, about 30% of people are still going without their cancer getting worse. That is the baseline.
Right. And for context, in this disease, 30% at 3 years for this specific patient population is actually typical, is what we expect from our current best treatments.
It's the benchmark.
Yeah, it's the benchmark. Usually when we compare a new drug to a standard of care, we are looking for a gap of maybe 10, 15%.
Right. I mean, you pop the champagne for 15% in a phase 3 trial.
Exactly. But here we are looking at a gap of over 50 percentage points. It is, statistically speaking, a landslide.
So that is our hook for today. We are unpacking a phase 3 clinical trial report titled Teclistamab and Daratumumab Efficacy in Refractory Multiple Myeloma.
A very dense title for a very exciting paper.
For sure. Our mission today is to understand how this specific combination, a bispecific antibody paired with a monoclonal antibody, is achieving these numbers. But more importantly, we need to understand the cost of that efficacy. Because as we know, there's no free lunch in cancer treatment.
No, there never is. And that's the critical nuance here. We are seeing record-breaking efficacy, but we're also seeing a safety profile that demands a lot of respect from the treating physician.
Okay, so let's unpack this. Starting with the context. We're talking about relapsed or refractory patients. So for the listener who follows oncology but maybe isn't a specialist in myeloma, let's pin down exactly who these patients are, because this isn't their first rodeo.
No, definitely not. These are patients who have been through the ringer. Specifically, the study looked at people who had received 1 to 3 prior lines of therapy.
Which implies a really difficult journey.
It does. It means they've been fighting this for a while.
And when we say refractory, what does that specifically mean for the humans in this study?
So refractory means their cancer either never responded to a previous treatment at all, or it stopped responding while they were actually still taking the drug.
Ah, okay. And relapsed.
Relapse means they had a period of remission, maybe a year or two where things looked good, but then the disease returned.
Got it. So these are not patients walking into the clinic on day 1 of their diagnosis.
Precisely. And that is what makes the results we're about to discuss so significant. Treating a fresh cancer is one thing, but treating a cancer that has already learned how to evade previous attacks is much, much harder. The cancer cells effectively evolved to survive.
They're the smart ones.
Yeah, they are the Darwinian survivors of the tumor population. So the standard of care for these patients, what the control group in this study received, is actually quite potent. It wasn't a placebo.
Oh, wait, we should be clear about that.
It's usually a combination of Daratumumab, a steroid like dexamethasone, and then the investigator's choice of either pomalidomide or bortezomib.
So the bar wasn't set low here. The control group was getting heavyweight drugs. Like, what doctors currently reach for in this exact situation?
Yes, it was a very high-quality standard of care, which just makes the performance of the challenger even more surprising.
Well, let's meet that challenger then. The study combines Daratumumab, which we know, with Teclistamab. Now, Teclistamab is a bispecific antibody. We hear this term buzzing around biotech a lot lately.
We do, yeah.
To me, that sounds like it's just indecisive, but I have a feeling it's actually doing double duty. Break that down for us. What is it actually doing at a cellular level that is different from a standard antibody?
It is exactly that, double duty. So think of a standard monoclonal antibody like Daratumumab as a homing beacon. It has 2 hands, but usually they're designed to grab the exact same thing.
Okay.
It sticks to one specific protein on a cell. In Daratumumab's case, it sticks to CD38 on the myeloma cell and flags it for destruction. It's a 1-to-1 interaction.
Right. Standard antibody equals one target.
Exactly. But a bispecific antibody, like Teclistamab, is engineered to be a bridge. It has 2 different binding arms. One arm grabs the B-cell maturation antigen, or BCMA.
And that's on the cancer.
Yes, that is expressed on the surface of the myeloma cell.
So that's the target. It grabs the bad guy.
Right. but the other arm grabs the CD3 receptor on the surface of a T cell.
The T cell being the immune system's infantry, the killer cell.
Correct. So teclistamab doesn't just flag the cancer so the immune system can find it later. It physically drags the T cell and the cancer cell together. It forces a synapse to form.
Wow.
I like to think of it like a bouncer at a club, grabbing a troublemaker with one hand and a security guard with the other, and literally handcuffing them together.
That is a very vivid image. It's forced intimacy between the immune system and the tumor.
That's exactly what it is. And the T cell is activated by that proximity. It releases perforins and granzymes to kill the cancer cell immediately. It forces the security guard to deal with the troublemaker right then and there.
And that's why it works in patients where other drugs have failed.
Yes. Even if the cancer has learned to hide from general systemic signals, it cannot hide when a T cell is physically tethered to its surface membrane.
Okay, then you add Daratumumab to the mix.
Why?
If Teclistamab is so good at handcuffing, what does the Daratumumab add? Is it just a more is better approach?
It's about attacking from multiple angles to prevent escape. Daratumumab targets CD38. Teclistamab targets BCMA. By hitting two different antigens simultaneously, you make it much harder for the tumor to mutate its way out of the problem.
So if the cancer cell decides to hide its BCMA code, the Daratumumab still sees the CD38 code.
Exactly. If it downregulates BCMA, the CD38 target is still there, and vice versa. Plus, Daratumumab has immunomodulatory effects that might actually help the T cells work better overall. It's a coordinated pincer movement using two totally different biological mechanisms.
A super team. All right, let's look at how they actually tested this. This wasn't a small pilot study, right? This was a massive undertaking.
A proper phase 3 trial.
We're looking at a total of 587 patients, and the randomization was almost perfectly split. 291 patients got the new super team Teclistamab plus Daratumumab. 296 got the control.
And this is important for the listener to grasp regarding the study design. This was an open-label trial.
Meaning the doctors and the patients knew what they were getting.
Yes. In complex cancer trials, with very different administration methods, like IV infusions versus subcutaneous injections, it's incredibly hard to blind the patients.
Sure, you'd know if you were getting an IV versus a shot.
Exactly. However, the primary endpoint progression-free survival was assessed by an independent review committee who did not know who was in which group.
So the data on efficacy is blinded and robust, even if the patients themselves knew what treatment they were on.
Correct. It keeps the bias out of the actual results.
Okay, let's get into that data. We dropped the 83% number in the intro, but we need to dissect what that actually means. The study followed these patients for a median of about 34.5 months. That's nearly 3 years. In the world of relapsed myeloma, 3 years is a lifetime.
It really is, and the separation between the curves happened almost immediately. By the time they hit the 36-month mark, the estimated progression-free survival rate for the control group, the standard care, was 29.7%.
Which, to be fair, aligns with what we historically expect for this patient population.
It does. It's a respectable number for third-line therapy. Nobody was slacking in the control group.
Right.
But the Teclistamab Daratumumab group was at an estimated 83.4%.
I just want to pause on that for a second. 83.4% of these patients who had already failed prior treatments were alive and their cancer hadn't grown after 3 years.
It's unprecedented. And the statistic that really drives this home, mathematically, is the hazard ratio.
Oh, I love a good hazard ratio explanation. Break it down for the listener who maybe skipped stats class.
Sure. So a hazard ratio of 1.0 would mean there's absolutely no difference between the two treatments. It's a tie.
Okay.
If the number is less than 1, the new treatment is better. Typically, a hazard ratio of 0.8 is considered a success in oncology. That's a 20% risk reduction. A hazard ratio of 0.6 is often called a blockbuster drug.
And what did this study show?
0.17.
0.17. That sounds almost impossibly low.
It implies an 83% reduction in the risk of disease progression or death compared to the standard of care. You almost never see a decimal point that low in a large phase 3 oncology trial.
Wow.
It suggests that the new combination isn't just better, it's in a completely different weight class.
It's essentially breaking the model we use to evaluate these things. But progression-free survival is one thing. That just means the cancer isn't getting worse. What about the response of the tumor itself? Did it just stop growing, or did it actually disappear?
That is where we look at overall response and complete response. The overall response, meaning did the cancer shrink at all, was 89% for the new combo versus 75.3% for the control.
Still respectable for the control, but the new guy clearly wins.
Right. But the quality of the response is what really matters here. We look at complete response or better, meaning the cancer is undetectable by standard tests. The new combo achieved 81.8%.
And the control?
Only 32.1%.
That is a massive chasm. That's the difference between we shrank the tumor and we can't even find the tumor.
And that leads us to the deepest level of success we can measure: minimal residual disease, or MRD.
This is the white glove test, right?
Exactly. Yeah. Think of it like cleaning a house. A standard response might mean the house looks clean to the naked eye. You walk in, it looks fine.
Dust is swept under the rug.
Right. MRD negativity is like going in with a white glove and a magnifying glass, specifically looking for one single cancer cell hidden among 100,000 healthy cells. That's a sensitivity of 10 to the -5.
So did the new combo clean house?
It did. In the Teclistamab Daratumumab group, 58.4% of patients achieved MRD negativity. They were clean at the molecular level.
And the standard group?
Just 17.1%.
So nearly 60% of patients on the new therapy had their cancer wiped out to a level that even hypersensitive machinery couldn't find.
Yeah.
That explains why the progression-free survival is so long. If you wipe the slate that clean, it naturally takes a very long time for the cancer to grow back.
That is the logic behind it. Deep responses lead to durable responses. And for a patient, that translates to years of life off the treadmill of constant failure and starting new treatments.
Why?
It connects back to that handcuff analogy. Because Teclistamab drags the T cell right to the target, it is exceptionally efficient at hunting down those straggler cells that traditional chemotherapy might miss.
However, and there is a massive however looming over this data.
Yeah.
We have to talk about the cost. Not the financial cost, but the physiological cost.
Yeah.
Because you don't rewire the immune system to attack cells this aggressively without some collateral damage.
No, you don't. That is the reality check we need to have. When you activate the immune system this aggressively, you risk collateral damage. This is where the excitement needs to be tempered with clinical reality.
So let's look at the safety data. Did these incredible results come with a heavier toll on the patient's bodies?
They did. We have to be very clear about that. The rate of serious adverse events was higher in the new group. It was 70.7% for Teclistamab Daratumumab compared to 62.4% in the control group.
So that's roughly an 8% increase in serious side effects. That's not negligible. And we aren't just talking about nausea or hair loss here, are we? What specifically is going wrong for these patients?
The main drivers are infections and cytokine release syndrome, or CRS.
Let's break those down. Why infections?
Because Teclistamab targets BCMA, which is found on plasma cells.
Yep.
It doesn't just kill the cancerous plasma cells. It wipes out your normal, healthy plasma cells, too.
All right.
Plasma cells are the factories that make your antibodies. So if you kill the factories, your body stops making antibodies altogether. You become hypogammaglobulinemic.
So you are curing the cancer, but you are stripping away the body's natural shields.
In a way, yes. You are left wide open to viral and bacterial infections. The study showed significantly higher rates of grade 3 or 4 infections in the experimental arm. And tragically, this did translate to mortality.
Right, let's look at that number. Deaths caused specifically by adverse events.
It was 7.1% in the new group versus 5.9% in the control.
That is a really difficult conversation to have with a patient. I have a drug that reduces your risk of cancer progression by 83%, but it has a slightly higher chance of killing you via a severe infection.
It is a profoundly difficult conversation, but you have to weigh that 1.2% excess mortality risk against the massive, massive reduction in cancer progression.
Right, because the alternative.
The alternative is the cancer. For a patient with relapsed myeloma, the cancer is a 100% fatal threat if unchecked. So the risk-benefit ratio still heavily favors the treatment, but it requires vigilant supportive care.
So it's definitely not a prescribe and forget drug.
Far from it. It requires a specialized center. Patients often need IVIG infusions to artificially replace the antibodies their bodies can't make anymore. They need prophylactic antibiotics and very, very close monitoring.
There's another angle to this safety data that I found really interesting. The study noted that more patients in the control group discontinued treatment due to adverse events than in the new group.
That's a great catch. Discontinuation due to adverse events was actually lower in the Teclistamab arm.
Why is that? I mean, If the side effects are more serious and the mortality is slightly higher, why are fewer people quitting the drug?
Two main reasons. One, the side effects like CRS, that intense immune storm we talked about, tend to happen early, usually in the first few doses, and then they subside. Once you get past that induction phase, it's remarkably tolerable.
Right, and the control group.
The control group was taking drugs like pomalidomide or bortezomib, which cause cumulative toxicity, like neuropathy nerve damage that just gets worse and worse over time until the patient can't tolerate it anymore.
So the poison essentially accumulates in the standard care, whereas the storm happens early in the new care and then passes.
Exactly. And the second reason is simply the efficacy. Patients feel better when their cancer is gone. In the control group, people are getting sick from the drugs, and the cancer is still there or growing, causing bone pain and other severe issues.
Right.
In the Teclistamab group, despite the infection risk, the overall disease control vastly improves their day-to-day quality of life.
That makes total sense. Success is a powerful motivator to stay on a therapy.
It really is. When you see the numbers dropping on your charts and you physically feel better, you are far more willing to put up with the management of those side effects.
So zooming out for a second, we have p-values of less than 0.001 for all the major comparisons in this study. The statistics are robust. This isn't a fluke or a statistical anomaly.
No, this is definitive proof of concept.
It feels to me like we are witnessing a fundamental shift in the philosophy of treating this disease. The standard of care, the control group, relied heavily on chemotherapy agents or proteasome inhibitors, but the new arm is entirely antibody-based.
That is the key insight. This is a chemotherapy-free regimen. We are moving away from cytotoxic drugs that just blindly poison dividing cells and toward precision immunotherapy.
Yeah.
It uses the body's own defense mechanisms, engineered and guided, rather than just poisoning the fast-growing cells and hoping the cancer dies before the patient does.
That's a fascinating distinction. We're moving from poisoning the cancer to actively hunting it.
That is a great way to put it. And the hunt is proving to be much, much more effective.
So to recap for our listener, if you are a patient with multiple myeloma who has had 1 to 3 prior treatments, this Teclistamab Daratumumab combination didn't just inch the bar forward, it vaulted over it.
Correct. It extended the time patients lived without the disease getting worse from a 30% chance at 3 years to an 83% chance.
With the caveat that it comes with a heightened risk of serious side effects, specifically infections, that need to be managed very carefully by the care team.
Yes. But in the world of relapsed myeloma, that is a trade-off many physicians and patients will likely be very willing to make. It transforms a fatal relapse into a chronic, manageable condition for years.
Here's where it gets really interesting for me, looking ahead. We've got this bispecific technology that acts like a matchmaker for T cells. We've got monoclonal antibodies. They're teaming up and just absolutely crushing the old standard.
It strongly suggests that the future of myeloma treatment, and perhaps many other cancers, might be entirely chemotherapy-free.
That's exactly what I was thinking. So here's the provocative thought I want to leave you with today. We all grew up thinking of chemo as the synonym for cancer treatment. But with bispecific antibodies showing this kind of absolute dominance and 83% reduction in risk, are we witnessing the beginning of the end for traditional chemotherapy regimens in myeloma?
It's a bold question. But if we can achieve deep, durable responses, clearing the disease to a microscopic level without the systemic toxicity of alkylating agents, we are entering a totally new era. It's like moving from carpet bombing to sniper fire.
Right?
The sniper is more dangerous if handled incorrectly, but it's infinitely more effective at taking out the actual target.
It is a brave new world for oncology, and frankly, a very hopeful one. We'll be keeping a close eye on how this treatment moves through regulatory approvals and makes its way into clinics.
Absolutely. There is still a lot more to learn, but today's data is a massive beacon of hope.
Thanks for diving in with us today. It's heavy material, but knowing that the science is moving this fast is undeniably hopeful. Keep those synapses firing and stay curious. We'll see you on the next deep dive.